What is rehab or rehabilitation? My name is Fred Bigueras, a board-certified sports and spine medicine physician in Virginia Beach, Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab Podcast. All right, the topic for today is the use of image guidance for injections. The traditional way of injections is referred to as landmark-based injections. This is where you have knowledge of what the target is, what structures are around it, and basically you guide the needle blind, but at least with an educated guess, heading towards the target. That's the way that we've done injections for several decades. More recently, particularly within sports medicine and pain medicine, we have started using image guidance. Now, there are two forms that are commonly used: X-ray guidance, also known as fluoroscopy, and also under ultrasound. Now, with X-rays, it's like your traditional X-ray of the knee or the chest. You place the needle so you can see the needle with an X-ray. Sometimes you use contrast to check the location, and then you deliver the medication. The same thing can be done with ultrasound. Now, there are pros and cons to each of these modalities. The pros with X-rays is that it's not landmark based. You can see the landmarks. You can advance the needle in real time. It'll give you a better idea of the overall depth and where the needle actually ends. When you're doing it landmark based, you really can't see the needle tip, and you're essentially advancing the needle and stopping with an educated guess. The downside to fluoroscopy is that there is X-ray exposure, which is relatively small, but still no one really needs any extra radiation. Now, with ultrasound, it is not radiation-based. It's also a lot more portable, and it's also, from a practice owner standpoint, it's a lot less expensive compared to owning a fluoroscopy machine and all the equipment that has to go along with it. So there are a lot of advantages, but the point of this talk is, why not use image guidance, or why should you? In my personal opinion, I do not think there is a good reason for physicians to not use image guidance when doing injections. With the advent particularly of ultrasound machines, you can, with almost 100% certainty, know exactly where and what you're injecting. This is obviously good information to have when you're sticking a needle into somebody. With the landmark-based approach, you depend a lot on your knowledge of anatomy and your experience. With experience, I think that you can certainly be a lot more reliable, but at the end of the day, it's an educated guess, and that will always be the major downside. When you advance the needle, basically just stop based off of your experience. I think that this is far enough, or this is too shallow, and you make adjustments accordingly. However, for the patient, this might not feel too good. When you are guiding the needle in such a manner, there's a lot more wiggle room, and it takes a little bit longer, and that unfortunately can sometimes translate into pain for the patient. Now, I'm not against landmark-based injections from a educational standpoint, because it is still an excellent skill to have. We don't always have equipment around us. It's also good to not only rely on technology, but also your overall tactile skill and experience. With landmark-based injections, the only way that you have confirmation that the injection is in the right spot is whether or not the patient reports relief. And this can be a little bit tricky, because it's ideal if the patient experiences relief. That does give you confirmation. However, if the painful structure is still painful, there's really two conclusions. Either you didn't hit the target, or the structure you did hit maybe just be very, very painful, and it just didn't work as well as we'd hoped. I personally learned using a landmark-based approach, but during my fellowship, I am now 10 plus years in practice. Fortunately, residents and fellows, and even medical students, ultrasound has been incorporated into their training. When I was in residency, we didn't even have an ultrasound machine available to us. So I guess that kind of dates me a little bit, but I think it speaks to how much medical education has changed over the years. But more importantly, it also demonstrates that the medical practice hasn't really caught up, because I still see a lot of people doing injections landmark based. But I see the arguments, it's like, well, in the landscape of decreasing reimbursement, the overhead associated with the equipment to have an ultrasound machine or an x-ray machine, it's an extra cost. From a business standpoint, it doesn't financially make sense, especially if the outcome is maybe sometimes negligible. However, I've heard seasoned attendings say this all the time. I have been practicing this type of injection for 20 years and I quote unquote know how to do it. And me buying an extra machine doesn't necessarily change that. It doesn't change how I practice. I certainly get that too. However, having done both styles for essentially equal amounts of time, I definitely see that there is a difference with the ultrasound. Because I can see the target, my injections are a lot faster for the patients, which translates to less discomfort, less anxiety, and it's generally much faster experience for the patient. However, the bigger thing is that I can guarantee where the medication is going. It really comes down to not just being accurate, but also being reliable. We acknowledge that everybody has similar anatomy, but there are certainly differences. As an osteopathic physician, I trained a lot with my hands from day one. So overall, I consider my general anatomy and my palpatory skills to be excellent. However, when I added ultrasound into my practice, I did have confirmation that with a lot of things, but then I also found certainly some surprises. I thought that I was over the particular structure by palpation, and then I stick an ultrasound on top of it, and I'm not as close as I thought. And that is really important, not just from a procedural standpoint, but from a learning standpoint. Now, I have practiced and performed enough injections that I've learned that you just cannot look at a particular body part and just size them up and say, you know what, I've done this injection a million times. I've seen this body type a million times. Therefore, I know exactly how to approach this because this person responded when I did it to them this way. It's therefore this person should have the same response. This is not a great way to practice, in my opinion, because the people that we help where there's relief, they're probably going to come back. However, the people that did get relief, they may not come back. So there's certainly a bias in terms of who comes back to the clinic, and what we conclude is the success rate of our injections. All I can say is adding ultrasound to my practice has made me very humble in terms of the human body and understanding my experience and limitations. Argument about overhead, I completely understand. I'm saying all these great things about image guidance, but at the end of the day, it is an extra cost to the clinic. From my standpoint, it really comes down to this question. If you can do something completely accurate, why wouldn't you do it? I guess you can guess when it's hard to know because that's all that you can do. But if you have access to those resources or you have those tools available to you, it only makes sense to guarantee or know more information about where you're placing a needle. The second most common factor that I hear is that it slows down my clinic. This is definitely true. Having an ultrasound machine certainly slows down the general flow. Because when you do a landmark-based injection, all you really need is your eyes, the medication, and a needle, and you should be good to go. However, when you have an ultrasound machine, you have to position the patient, you have to clean the area, you have to clean the machine. There's even positioning the machine if it's on a cart. So there's a lot of steps, and it does take extra time. So I definitely appreciate the flow factor. However, it still goes back to, if it takes a little bit longer to be 100% correct, wouldn't you rather be 100% correct? And again, this is still something that I don't understand how this is something that's negotiable. In my clinic, I see a lot of patients that are second opinions. It's now 2024, and I know that the technology is available. It's certainly cheaper. It's not zero, but it's definitely cheaper. And I still see patients who have seen orthopedic surgeons, physiatrists, family medicine, and there's a lot of them still doing landmark based injections for the knee. It doesn't make any sense to me. Well, it does make sense why, but I'll get into that a little bit later. Just like anything, the more you practice doing ultrasound injections, you get faster. That being said, my clinic is structured differently. Because I'm out of network, I have made the conscious effort to spend more than 7 minutes with my patient. That's not the typical orthopedic or sports medicine clinic. The typical clinic, you have 7 minutes, you have 50 patients in a clinic day. Again, it goes back to the time and the flow of the clinic. But it was ultimately my personal choice. I just never really was comfortable just burning through patients and just, essentially using a needle and guessing. That was just something that I never really felt comfortable with. In the past, there was maybe a knowledge gap, but because there weren't that many practitioners doing these type of injections. However, there's not really an excuse anymore. If you were a late adopter to some of this technology where you're having to learn how to use ultrasound or your X-ray guidance after residency or fellowship, there's definitely a learning curve. And in a bit busy practice, there's not a lot of free time to learn a brand new skill when you've been trained to do it a certain way. Incentive just simply isn't there because a lot of times, as long as the patient feels better, you think you're doing pretty good. However, these days, ultrasound has been incorporated even at the medical school level. I didn't use an ultrasound machine until basically the end of my fellowship. So I just personally don't see why practices aren't electing to at least make the change to start using better technology to guide needles, particularly from a diagnostic standpoint. Knowing and guaranteeing where your medication is going is extremely important because when you do a diagnostic block, the assumption is that you are targeting a particular structure that is going to impact a clinical decision. If you're going to make a surgical decision based off of a block, you better make sure that you are targeting accurately and reliably the structure because you don't want to block the wrong structure and someone has a surgery because of it and then they end up having persistent symptoms afterwards. Just nobody wins in that situation. Everybody looks bad. The person doing the injection, the surgeon, it's just not a great situation. However, I do understand I'm making it sound so simple, but it's not simple. It goes back to if it was your own body, wouldn't you want someone to be as accurate as possible? I understand the pressures at the clinic and why people have to move at a certain speed and the cost and benefit ratio aspects of things. But at the end of the day, it has to be driven by what's good for the patient. And that's just the bottom line. If I had my knee injection, I would want someone to use image guidance. Even if they've had 20 to 30 years of practice, I would strongly question them why they're not using ultrasound. As I've said, I've done this enough that I know that it's not as simple as it seems. Our anatomy is very, very deceptive, but ultrasound guidance or x-ray guidance eliminates that factor. If anything, it gives you extra knowledge. Why wouldn't you want extra information at a relatively lower cost? It doesn't make sense to me why you wouldn't want to know more when you're doing these type of injections. When you're sticking a needle into someone's body, you should be 100% accurate. We've all had our blood drawn and someone who isn't as experienced, and then we just keep getting poked and poked and poked and poked. On the other side of that, the patient doesn't get relief. What makes things worse is that sometimes they come away with a very negative experience overall from the injection. Maybe this person doesn't tolerate the needle very well. Maybe they have a fear of needles. Maybe the needle was in the wrong place and the medication, while they're placing it, just made it extremely painful. To me, that's like the worst case scenario where the patient doesn't get any relief and it's the wrong target and they walk away with a negative experience, increased fear of injections, and then they also conclude that it quote unquote doesn't work. That really it skews negatively the patient's view of future injections and even maybe of the person doing it. A lot of my discussion with patients is sometimes trying to convince them to let me give it a try. The experience of the injection can be very scary for people, but again, I don't want to get too deep in the weeds with that. At the end of the day, the bottom line is image guidance, I believe, should be the standard of care. If your physician is not doing injections with image guidance, I would ask them why not? Why don't you use some sort of image guidance? Because it's very clear in the literature there is a better way to do it. Before we finish up this episode, I wanted to leave you with these questions to think about. Is accuracy overrated? Is having more information helpful? Is there a condition or procedure where more information is actually bad? If you have a preference for landmark-based injections, what would make you want to adopt image guidance in your current practice? Thanks again for listening, everybody. Have a good one. Thank you for listening to the Talking Rehab Podcast. I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.